What happened over the past year or so are three major studies that tested adjuvant therapy in melanoma, starting with September of 2017 at the ESMO meeting in Madrid. Two major studies were presented. The first was the Checkmate 238 study, which tested nivolumab, anti-PD-1 adjuvant immunotherapy for patients with high-risk melanoma, and compared to the standard at the time, ipilimumab, at the high toxic dose of 10 milligram per kilogram. That study was positive. There was significant improvement in reducing of the cancer coming back, so the risk of relapse in this patient population. And thankfully, soon after, adopted by the clinical practice and achieved FDA approval and is now a standard of care. The second option was for patients with BRAF-mutant melanoma. During the same meeting in September of 2017 was the COMBI-AD study, which tested dabrafenib, trametinib combination, so BRAF and MEK inhibitors, versus placebo in patients with high-risk melanoma whose tumor had the BRAF mutation. So these are patients with BRAF-mutant melanoma. There again, in the COMBI-AD, we've seen significant improvement, really unprecedented improvement in reducing the risk of relapse for this patient population. Again, changing the clinical practice for this patient population. More recently now, basically on Sunday, here at AACR, we've seen the presentation of the Keynote 054 study, which is the adjuvant study of pembrolizumab, also anti-PD-1, compared to placebo in patients with high-risk surgically resected melanoma. So now the field has changed so dramatically over the past year by new major options that are certainly effective as tested in major randomized clinical trials, but also they are less toxic, there's no question, less of an impact on the quality of life of our patients. And the expectations that we will see really major improvement in the outcome of our patients over the coming years, really, with these major data coming out.